Hello everybody, my name's Elise Smithers and today we're going to go over a dermatological case presentation. I'll begin with presenting to you a dermatological case. We'll then explore the provisional diagnosis followed by 5 differential diagnoses. So to begin off with our case study, we have a 46-year-old patient that attends a clinic for general nail care. He asks about a change he has noticed in his left hallux nail, which he tells you first appeared about 3 months ago. The nail has developed a blackish brown discoloration to the distal lateral nail. It is enlarged in surface area over time, and the patient is uncertain whether he caused trauma to the area, but admits it is possible because he has been renovating his house for several months now. His medical history is otherwise unremarkable. Okay, now on to our provisional diagnosis of onychomycosis. So the reasoning for this provisional diagnosis is the fact that the patient is 46 years old and onychomycosis is common with increased age. It most often involves the great toenail as noted in the patient case. Total distal lateral location of the pigmented onychomycosis is very typical in onychomycosis. Furthermore, it often spreads and becomes larger in surface area and eventually develops total dystrophic nail. Considering the patient is completing renovations to the house and has been for several months now, it is also very likely that he may have caused trauma to his nail bed whilst in work boots. He may be experiencing increased sweating if he's not wearing some good moisture wicking socks. And so a traumatized nail in combination with sweat, moisture, is a perfect environment for the development of fungal infection. Some of the factors for ruling out onychomycosis in this individual is the fact that they don't really have any developing tinea pedis to the plantar surface or interdigital spaces of the feet. So like as I said, you can't see any peeling or erythema to these areas. There's no signs of paronychia, that is infection of the surrounding nail. And there's no distal onycholysis, which is lifting of the distal nail. So despite all these things not being present, it doesn't mean that the patient won't experience these symptoms as the condition progresses, but just at this stage, these aren't present. And these are the only things I can think of that could potentially rule out onychomycosis. Now, onto our differential diagnoses. We have 5 that we'll be touching on. The first one we'll be discussing is acral lentiginous melanoma. So the reason for this differential diagnosis is the fact that it originates below the nail. The majority of these cases arise in people that are aged over 40. Often the discoloration of the nail is asymmetrical. The borders are irregular and blurred. There is a blackish brown discoloration and the diameter is usually greater than 6 millimeters. This lesion is often evolving/increasing in size, which is all evident in this patient case. Reasoning for ruling out acral lentiginous melanoma is the fact that this condition is most common in individuals with darker skin and is least common in Caucasians. This takes us into our second differential diagnosis of melanechia. And the reason that this is a differential diagnosis is the fact that this condition affects the nail matrix and nail. Often is a black or brown discoloration, and it most commonly affects the hallux. It can be triggered by trauma, such as the patient's current house renovations, potentially causing trauma whilst wearing those boots. And some reasons for ruling out melanechia is that often melanechia occurs at the proximal eponychium. It presents as a diffuse or longitudinal band. Furthermore, Caucasian people are less commonly affected. We then have subungual hematoma. And the reason we are suggesting this as a differential diagnosis is the fact that this pathology appears to be trapped between the nail bed and the nail plate. It's possibly secondary due to trauma from wearing from wearing boots and always participating in renovations. He may have injured the toe. Usually this presents as a single discolored or pigmented nail as seen in the image. And this may appear black, indicating old trauma. And again, there is some black discoloration there, as you can see. Usually this type of thing resolves slowly after months or years. Some reasons for ruling out subungual hematoma is the fact that usually it would be associated with some swelling, erythema of the surrounding tissues of the nail. The nail might be damaged with onycholysis, so lifting of the distal nail bed. There might be thickening of the hyponychium. Often it's associated with pain, and this often discoloration, the dark discoloration often grows out distally. And so those symptoms I've just discussed, they're not present. And so this is why I would rule out subungual hematoma. In regards to Pseudomonas nail infection, this has been chosen as a differential diagnosis because bacteria widespread in water and soil can create infection and trauma. It can create infection to a traumatized nail bed. And this individual may have been outside, might have got some contaminated dirt or water in his boot, and that has potentially infected his traumatized nail. So also considering that the individual is conducting the work renovations, this type of thing can be very stressful and it can take its toll on an individual and their family. And so when you're stressed, often individuals will experience a lowered immunity. And so if this patient is stressed from his renovations, he's more inclined to have a lowered immunity and therefore become infected with a Pseudomonas infection. Some reasons to rule out Pseudomonas nail infection include the fact that often a Pseudomonas nail is dark green in color. There's often offensive odor associated with this condition, and often you'll find some surrounding erythematous skin, which can be hemorrhagic or necrotic. There may be neighboring deep abscesses, subcutaneous nodules. There may be some associated cellulitis and potentially even necroticizing fasciitis and eschar of the surrounding tissues. And none of these are evident in this case, and so this is why I would rule out Pseudomonas nail infection. And this brings us to our last differential diagnosis, and the reason we've chosen psoriatic nail is the fact that it can occur at any age and any race. It may be secondary to nail trauma associated with his renovations, and it can affect any part of one or more nails. Reasons for ruling out psoriatic nail is the fact that there is no nail pitting, there's no significant red or yellow discoloration. He has an unremarkable medical history, no diagnosis of psoriasis, and psoriatic nail is rarely diagnosed in an isolated diagnosis. There's no signs of onycholysis or any translucent yellow-red discoloration with oil drop or salmon patches. There is no subungual hyperkeratosis or scaling under the nail or transverse lines and ridges. And furthermore, there is no psoriatic inflammation surrounding the nail plate, crumbling, splinter hemorrhaging, or spotted lunula. And so those are some of the reasons ruling out psoriatic nail. Thank you everybody for listening. I hope you really enjoyed this presentation. Just be mindful that when you are treating a patient, it is really important to consider your differential diagnoses along with your provisional. This is because if your initial treatment plan for your provisional diagnosis is unsuccessful, it is important to know where you'll be heading next in your treatment plan. And if you do know your differentials, then this could guide you further down the track and ensure positive health outcomes. Thank you, everybody.